Hi class and welcome to chapter 18. This is the final chapter in this module. This chapter is divided into three parts. Part A is a review on the structural anatomy of veins and arteries. So you're still responsible for the material in part A, but I'm not going to go over it in this video. What we will go over are parts B and C, if we can try to get through both of them in one video, and we'll look at the physiology of circulation, so how blood travels through. We'll look at flow, pressure, and resistance. Blood flow, first of all, is the volume of blood flowing through a vessel, organ, or entire circulation in a given period. It's always measured in milliliters per minute, and it's equivalent to cardiac output, as we talked about in chapter 17 for the entire vascular system. Overall, the blood flow in the body is relatively constant when at rest, but at any given moment varies at individual organ level based on needs. So it can increase or decrease. But blood pressure then is the force per unit area exerted on a wall of a blood vessel by the blood. And this is expressed in millimeters of mercury. It's measured as systemic arterial blood pressure in large arteries near the heart. And the pressure gradient provides a driving force that keeps blood always moving from an area of high to low pressure throughout your arteries and veins. Resistance then, or also known as peripheral resistance, is the opposition to flow. It's the measurement of the amount of friction the blood encounters with vessel walls, generally in your peripheral or systemic circulation. And there's three important sources of resistance: blood viscosity, total blood vessel length, and blood vessel diameter. Blood viscosity is the thickness or stickiness of blood due to formed elements in plasma proteins. The greater the viscosity, the less easily molecules are able to slide past each other. Increased viscosity equals increased resistance. Total blood vessel length. The longer the vessel, the greater the resistance encountered as well, because it just has a longer area to travel through. Blood vessel diameter has the greatest influence on resistance. Its frequent changes alter peripheral resistance, and viscosity and blood vessel length are relatively more constant. Fluid close to the walls moves more slowly than in the middle of the tube, and this is what we call lamellar flow. And resistance varies inversely with the fourth power vessel radius. So this just means that if the radius of the blood vessel increases, resistance decreases. And that makes sense. If you're shooting water out of a fire hose, there's less resistance, whereas if you would have that same pressure built up with a garden hose. In an example, if the radius is doubled, resistance will drop to 1/16 as a month. So that just means if we double the radius, or kind of the area of the circle of the artery, it'll be much less resistance and blood can flow more easily through. Blood vessel diameter. So your small diameter arterioles are the major determinants of peripheral resistance. The radius changes frequently in contrast to larger arteries that do not change often. Any abrupt changes in the vessel diameter or obstacles, such as a fatty plaque from atherosclerosis, can also increase resistance because it's serving as to kind of block the blood flow. Laminar flow is disrupted and becomes turbulent flow, which is irregular flow that causes increased resistance. And this is just showing the idea of resistance, drinking a milkshake out of two different types of straws. There's much less resistance in the straw with a larger diameter. You can get more milkshake up, versus a smaller diameter, you'll encounter a lot more resistance. Blood flow then is directly proportional to blood pressure gradient, which is the change in pressure. That little triangle means change in. So as the change in pressure increases, blood flow speeds up. Blood flow is inversely proportional to peripheral resistance. So if resistance increases, blood flow decreases. So we get this equation. Being familiar with the equation is fine. I probably won't ask you too many questions on calculating things. Resistance is more important in influencing local blood flow because it's easily changed by altering the blood vessel diameter. Systemic blood pressure then is the pumping action of the heart, which generates the blood flow. Pressure results when flow is opposed by any sort of resistance, and systemic pressure will always be highest in the aorta and decline throughout the pathway. and there's a steepest drop occurring in the arterioles. So you can see here the blood pressure in various blood vessels of the systemic circulation. Blood pressure is greatest in your aorta, directly exiting the blood, and then it really drops down where you don't have much blood pressure at all in the veins and vena cava that are taking blood back to the heart. Arterial blood pressure is determined by two factors: elasticity, which is compliance or distensibility of the arteries close to the heart, so how well they kind of stretch and recoil, and the volume of blood forced into them at any time. The blood pressure near the heart is pulsatile, meaning you can feel the pulse of that, and it rises and falls with each heartbeat. Systolic pressure is the pressure exerted in the aorta during ventricular contraction. The left ventricle pumps blood into your aorta, which imparts a kinetic energy that stretches your aorta. And the average blood pressure of the systolic pressure in a normal adult is 120 millimeters of mercury. The diastolic pressure then is just the lowest level of aortic pressure when the heart is at rest. And the pulse pressure is the difference between systolic and diastolic pressure. The word pulse itself has to do with the throbbing of arteries due to the difference in pulse pressures, which can be felt under the skin. Mean arterial pressure is the pressure that propels blood to the tissues. The pulse pressure phases out near the end of the arterial tree, and the flow at this point will be non-pulsatile with a steady mean arterial pressure. The heart spends more time in diastole, so not just a simple average of diastole and systole. So here's the mean arterial pressure. It's calculated by adding diastolic pressure plus 1/3 pulse pressure. So for example, if your blood pressure is 120/80, the pulse pressure is the difference, so we get 40. And then the mean arterial pressure is just this diastolic pressure, which is 80, plus 1/3 of the pulse pressure. So we do 1/3 times 40 plus 80, and we get about 93 millimeters of mercury, and that's our arterial blood pressure. The pulse pressure and mean arterial pressures both decline with increasing distance from the heart. So there's a little bit of review. This equation for how mean arterial pressure is calculated, I do want you to know that's a little more common in the medical field that you might find. Clinical monitoring of circulatory efficiency, you can take a vital sign, which is taking your pulse and blood pressure, along with the respiratory rate and body temperature. Taking a pulse, the radial pulse taken at the wrist most routinely used, but there's other clinically important pulse points throughout the body. Pressure points are areas where arteries are close to the body surface, and they can be compressed to stop blood flow in the event of a hemorrhaging. So here are the body sites where the pulse is most easily palpated, and you can try this on yourself. The superficial femoral artery on your forehead, the facial artery, the common carotid artery, that's the one in the neck, the brachial artery, femoral artery, radial artery, popliteal artery, and then the dorsalis pedis artery. So you can even feel the pulse on the foot. Measuring blood pressure, so systemic arterial blood pressure is measured indirectly by what we call an oscillatory method. And this is using a sphygmomanometer. You can say that 10 times fast. And this is where many of you probably know how to do this if you're some sort of medical assistant or have any sort of background already in health. You wrap the cuff around the arm superior to the elbow, and then you increase the pressure in cuff until it exceeds systolic pressure in the brachial artery, and then it closes it off. And then your pressure will be released slowly as the examiner listens for the sounds of corticough with a stethoscope. So measuring the blood pressure, the systolic pressure is normally less than 120, and this is the pressure when the sounds first occur as blood starts to spurt through the artery. So when you take someone's blood pressure, the cuff closes off the brachial artery, and then you slowly release pressure until you can hear blood starting to spurt through the artery. And that first sound you hear is the systolic pressure, and you're recording that using a blood pressure cuff measurement, and hopefully it'll be 120 or lower. Diastolic pressure, then, it's normally less than 80. This will be the pressure when the sounds disappear completely because the artery is no longer constricted. You've completely let out the pressure from the cuff, so blood can flow freely again, so you don't hear anything anymore. Capillary blood pressures range from 35 at the beginning of the capillary bed to about 17. Low capillary pressure is very desirable because high blood pressure would rupture these very thin-walled capillaries, and most capillaries are very permeable, so low pressure forces the filtrate into interstitial spaces. Venous blood pressure changes little during the cardiac cycle. It's the small pressure gradient, it's only about 15, so pressure is very low in your veins. If a vein is cut, the low pressure of the venous system causes blood to flow out smoothly, but if an artery is cut, blood will spurt out because the pressure is much higher. The low pressure is due to cumulative effects of a peripheral resistance, and the energy of the blood pressure is lost as heat during each circuit. Low pressure of the venous side requires adaptations to help with venous return. Factors aiding the venous return, so this means blood flow back to the heart, are the muscular pump, which is the contraction of skeletal muscles, which kind of milks the blood back toward the heart, the valves preventing backflow. The respiratory pump, which you have pressure changes during breathing, which move the blood towards the heart by squeezing the abdominal veins as the thoracic veins expand. And then you have sympathetic venoconstriction. Under sympathetic control, smooth muscles constrict, pushing blood back towards the heart. And this is a great look at the muscular pump. So how the muscles will contract and actually squeeze the blood back up through the veins to try to increase return back to the heart more quickly. Regulation of blood pressure, maintaining blood pressure requires the cooperation of heart, blood vessels, and kidneys. They're all supervised by the brain, and there's three main factors regulating blood pressure: the cardiac output, peripheral resistance, and blood volume. And blood pressure varies directly with cardiac output, peripheral resistance, and blood volume. So here are some equations. You can rearrange some of the equations to show that blood pressure is directly proportional to cardiac output and peripheral resistance. More equations describing again what cardiac output was, so we can kind of get here what mean arterial pressure will be equal to if we plug in what cardiac output is equal to. So anything in general, anything that increases stroke volume, heart rate, or resistance will also increase mean arterial pressure. Stroke volume is affected by venous return, heart rate is maintained by your brain, the medullary centers, and resistance is affected mostly by vessel diameter. Regulation of blood pressure factors can also be affected by short-term regulation, your neural controls, hormonal controls, or long-term regulation from your kidney and renal controls. And these are just a kind of a good review of major factors that increase mean arterial pressure. Neural controls, so there's two main neural mechanisms that help to control peripheral resistance. Mean arterial pressure is maintained by the blood vessel diameter, and they can also be altered, or can also alter blood distribution to organs in response to a specific demand. These neural controls operate via reflex arcs that involve the cardiovascular center of the medulla, the baroreceptors, chemoreceptors, and higher brain centers. The role of the cardiovascular center is seen here. It's composed of clusters of sympathetic neurons in the medulla. It consists of cardiac centers, the vasomotor center. Basically, the cardiovascular center will receive input from the baroreceptors, chemoreceptors, and brain receptors. The baroreceptor reflexes, these are located in the carotid sinuses, the aortic arch, and walls of large arteries of the neck and thorax. And if mean arterial pressure is too high, the increased blood pressure will stimulate these baroreceptors to increase input to the vasomotor center. These will inhibit the vasomotor and cardioacceleratory center. So it will stimulate the cardioinhibitory center to try to decrease blood pressure. The baroreceptor reflex resulting decrease in blood pressure is due to two mechanisms: vasodilation, so decreased output from your vasomotor center in the brain causes dilation of your arterioles. The arterial vasodilation reduces peripheral resistance, so mean arterial pressure will fall, and venodilation shifts blood to venous reservoirs. That just means that it'll try to push the blood into these reservoirs of your large veins. That will also decrease venous return and cardiac output. Decreased cardiac output, these are impulses to the cardiac centers, which will inhibit sympathetic activity and stimulate the parasympathetic nervous system to try to reduce heart rate, reduce contractility, This will reduce cardiac output, which will reduce mean arterial pressure. If mean arterial pressure is too low, the reflex vasoconstriction will be initiated that increases cardiac output and blood pressure. So for example, when you stand up really fast, your blood pressure falls and triggers the carotid sinus reflex that ensures that enough blood gets to your brain, and also the aortic reflex that maintains the blood pressure in the systemic circulation. Baroreceptors are ineffective if altered blood pressure is sustained. So for example, if it becomes adapted to high blood pressure or hypertension, so it's not triggered by elevated blood pressure levels. So this is just a good baroreceptor reflex showing the balance that helps to maintain blood pressure and the distant things that occur to maintain blood pressure. And you can read through those as each will do. The chemoreceptor reflex in the aortic arch and large arteries of the neck, these will detect increases of carbon dioxide or a drop in pH or oxygen. This causes increased blood pressure by signaling the cardioacceleratory center to increase cardiac output and signaling the vasomotor center to increase vasoconstriction. Influence of higher brainceptors. So this is just kind of a review of higher brainceptors in the brain and the effect that they'll have on trying to short-term regulate blood pressure. Hormonal controls then of blood pressure. Hormones regulate blood pressure in short term via changes in peripheral resistance. So the adrenal medulla hormones like epinephrine and norepinephrine from your adrenal gland increase cardiac output and vasoconstriction. Angiotensin 2 stimulates vasoconstriction, and ADH, high enough levels, can also cause vasoconstriction. Atrial natriuretic peptide will decrease blood pressure by antagonizing aldosterone, causing decreased blood volume. And this is just a good kind of review of the hormones and what effects they have on blood pressure. Long-term mechanisms we talk about then your kidney, so renal regulation. You have baroreceptors that quickly adapt to chronic high or low blood pressure, so are ineffective for long-term regulation. So long-term mechanisms to control blood pressure are by altering the blood volume, and this happens in your kidneys. So kidneys regulate arterial blood pressure by direct renal mechanism and indirect renal mechanism through the renin-angiotensin-aldosterone system. Direct renal mechanism will alter blood volume independently of hormones. So increased blood pressure or blood volume causes the elimination of more urine, thus reducing blood pressure and blood volume. And decreased blood pressure or blood volume causes the kidneys to conserve water and blood pressure rises. So this is just a look at the direct and indirect control and mechanisms for renal control of blood pressure. The renin-angiotensin-aldosterone system is kind of your body's indirect way to regulate blood pressure. Decreased arterial blood pressures cause release of renin from the kidneys. Renin enters the blood and catalyzes the conversion of angiotensinogen from your liver to angiotensin 1. And then we have an angiotensin converting enzyme from the lungs, which converts angiotensin 1 to angiotensin 2. And then angiotensin 2 acts in 4 ways to stabilize your arterial blood pressure and extracellular fluid levels. That's what ECF is. It stimulates aldosterone secretion, which will retain water, causes ADH release from the posterior pituitary. It triggers your hypothalamic thirst center to drink more water, and it also acts as a potent vasoconstrictor, directly increasing blood pressure. So summary of blood pressure regulation mechanisms. The goal of blood pressure regulation, again, is to keep blood pressure high enough to provide adequate tissue perfusion or diffusion, but not so high that blood vessels are damaged. So for example, if blood pressure to the brain is too low, perfusion is inadequate and the person will lose consciousness. If blood pressure to the brain is too high, the person could have a stroke. So these are all the factors that increase mean arterial pressure. A good review slide, and it's nice. Below the slide, there's lots of notes that explain each slide. So we'll end this PowerPoint talking a little bit about the regulation of blood pressure, because I'm sure we know people with high blood pressure. That's probably environmental. My dad is one. He was overweight for a long time, and he totally had to change his diet. So let's talk about homeostatic imbalances in blood pressure. Transient elevations in blood pressure occur normally during changes in posture, physical exertion, emotional upset, and fever. So these are normal changes. But age, sex, your weight, your race, your mood, and your posture may also cause blood pressure to vary. Hypertension is high blood pressure. It's the sustained elevated arterial pressure of 140 over 90. Remember, 120 over 80 is normal. Pre-hypertension, if the values are elevated, but not yet in that hypertension range, it may be transient due to fever, physical exertion, or emotional upset. And it's often persistent in obese people. So my dad was overweight for a while. He was in the pre-hypertension stage, and now he's just always in the hypertension stage, even though he's doing a lot better with his diet and exercise. Prolonged hypertension. Why is high blood pressure bad? Well, if you have high blood pressure and it's prolonged, it's a major cause of heart failure because your heart is working harder than it needs to pump out and get over all this blood pressure that it has to resist. Vascular disease, renal failure, and stroke. The myocardium of the heart will enlarge, it will weaken, it become flabby, and it can also accelerate atherosclerosis. Primary hypertension is 90% of hypertensive conditions. There's no underlying cause identified. Risk factors include hereditary, so it can be genetic, diet, obesity, your age, diabetes, stress, and smoking is huge. I cannot tell you guys enough, please do not smoke. There's a whole slew of bad things associated with smoking. I'll get off my soapbox now. There's no cure, but it can be controlled by restricting salt, fat, cholesterol intake, increase exercise, losing weight, stop smoking, and if you take an antihypertensive drug. Secondary hypertension is less common, and it's due to an identifiable disorder like an obstructive artery in your kidneys, kidney disease, endocrine disorders such as hyperthyroidism or Cushing syndrome, and the treatment focuses on correcting the underlying cause. Hypotension is extremely low blood pressure. It's anything below 90 over 60. It's usually not a concern unless it causes inadequate blood flow to the tissues, and it's often associated with long life and lack of cardiovascular illness. Hypotension, we call orthostatic hypotension, which is just temporary low blood pressure and dizziness when you suddenly rise from a sitting or reclining position. Chronic hypotension is the hint of poor nutrition and a warning sign for Addison's disease or hypothyroidism. And acute hypotension is an important sign of circulatory shock. Circulatory shock, then, is a condition where your blood vessels are inadequately filled and cannot circulate blood normally. An inadequate blood flow cannot meet the tissue needs. Hypophalemic shock results from a large-scale blood loss. Vascular shock results from extreme vasodilation and decreased peripheral resistance. And cardiogenic shock results when an inefficient heart cannot sustain adequate circulation. And I think what I'm going to do is, this was pretty lengthy, so I'll do part C in another lecture video. Thanks for listening, guys.